So we've reached the final session of our seminar. Dr. Newman will be touching upon a very interesting issue.
And UNICEF in matters of breastfeeding, and is well known around the world through the internet. And he gives advices in all of us in very difficult breastfeeding items. Thank you very much again.
Hello. Okay, so this talk is, I guess, the last of the day. I hope you're not going to sleep too much. The talk is called When Breastfeeding is Not Contraindicated, and the answer is hardly ever is breastfeeding contraindicated. I'm finished. Thank you. Okay. First of all, artificial baby milks are only approximations to outdated notions of what we think breast milk is or was. And that's an important point, because the formula companies all tell us that formula is almost the same as breast milk. And when something is almost the same, we believe perhaps that it makes no difference. But formula is very different from breast milk. And formula is very much different from breastfeeding. And I think we always have to remember that breast milk is not breastfeeding, that breastfeeding is much more than breast milk. So, if you go to this link, you will find our article on how formula is so different from breast milk or from breastfeeding. And one of the important things about this is that the formula companies tell us how good their formulas are. And over the years, they've added things, they've changed things, they've decreased the amount of protein in the formulas, and they're telling us that these formulas are so good now. But if you think about it for a second, they are also telling us that all the formulas they had 10 years ago, 30 years ago, were completely insufficient, were not good. But they don't mention that. Okay, so breastfeeding, as you see, is a special relationship. It's a close relationship. It's something very special, as many of you know. Toddlers breastfeed, and this is good. And I think that we have to remember, and what I talked about yesterday, the breastfeeding toddler, I think that when we start to tell mothers that they cannot breastfeed for some reason, we are depriving them of this very special relationship. And I think you can see that there's a special relationship between this mother and her breastfeeding toddler, and maybe a special relationship this way too. I'm not too sure how that woman was thinking. Here is breastfeeding in red. The mother is pregnant and still breastfeeding, and there's no reason she cannot continue breastfeeding even though she's pregnant, although many doctors will tell the mother that she must stop, and this is not true. So, here is an email. She is still very attached to nursing. Still nurses at least 3 times a day and during the night, since we are co-sleeping, so basically on demand. I had tried to explain to her that we are not nursing anymore at night, to start weaning her, but she will not take anything but the breast. Last night she cried until she got the breast finally, and then she would not let me go. And I think that this is one thing that many people, especially doctors, do not understand. That when we tell a mother that her breastfeeding toddler must stop breastfeeding, that they have no idea that this is going to happen. That forcing a child to stop, particularly a toddler, to stop breastfeeding is an emotionally traumatic situation. And this also has to be taken into account when we say to mothers, you must stop breastfeeding. So some people would find this terrible, that this child, obviously no longer a baby, still breastfeeds and co-sleeps, but breastfeeding is a very important thing for her, and it is traumatic, emotionally and physically, to force a toddler to stop breastfeeding. And it's not terrible, by the way. This issue comes up over and over again in custody cases and access cases, drugs given to mothers, admission of the mother to hospital, and so forth. Here's another. I had an accident 4 days ago. I have 2 sprained ankles and a disc hernia. I have to take medication. It helps to ease the pain. And otherwise, I wouldn't be able to go to work and walk or just stand. I have been told that I cannot breastfeed with this medication, so I stopped. But he cries, undresses me. That's a precocious child. Wants milk, screams. It pains me to see him like that. I wanted to stop breastfeeding when he was ready. I did not offer him milk when he didn't ask for it. I wanted to respect his rhythm and told myself he would be like his big brother who stopped breastfeeding on his own. I really want him to have what he needs, but I cannot manage the pain right now. I waited before taking the medication so that he could have milk at night and in the morning, but then I couldn't sleep because of the pain. I don't know what to do. Well, this was an easy one. Take the medication, keep breastfeeding. Don't doctors understand how different the breastfeeding toddler is from a baby? Yes, the baby won't necessarily act like this, but we're depriving babies all the time. Formulas occasionally save lives. That's right. There are certain babies who need. Babies with galactosemia, for example, cannot breastfeed if they've got the full syndrome. It can be useful therapeutically. It's true. Some women do not produce all the milk the baby needs, and we may have to supplement. But they should be considered drugs with possible short-term, medium-term, and long-term side effects, and used only if necessary, not for convenience. Safe donated milk is preferred to formula as well. And at least in North America, I don't know in Europe, there are now mothers who are donating milk through the internet, and there are, on the internet, they talk about how to do this safely, and there have been no problems. So, breastfeeding and maternal medication. This is an article on our website as well. Click the link and you will get it in English. There are principles for the use of drug use. I mean, we don't always follow these principles, but use medication only if necessary. What a brilliant idea. I didn't make this up. This is something that we need to do all the time. Older and better known drugs are better for breastfeeding women, and newer drugs are not necessarily safer either for the mother or are better therapeutically. Don't forget, just like formula companies, drug companies say now, this is a great advantage over the previous drugs that we always used. And boy, not only is it better for the patient, it's better for us because now we charge a lot more because we still have a patent. Use drugs which are least toxic. Again, it makes sense, doesn't it? Use drugs which are used for infants. If an infant can take it, why can't the mother take it and continue breastfeeding? Of course. Be flexible and look for alternatives. Drugs are generally safer for nursing babies if they are highly protein bound. Only drugs that are not protein bound in the blood can get into the milk. So the higher the protein binding, the less of the drug that gets into the milk. Short half-life. A drug with a short half-life is safer generally than a drug with a long half-life. If it's poorly absorbed from the gastrointestinal tract. So we have a number of possibilities here. So one of the most common drugs used in medicine these days are the proton pump inhibitors that people take for reflux and stuff like that. Okay, the mother has a covering. When you take it yourself, there's a covering over the drug that protects it from the stomach acid. But when the baby gets it in the milk, it doesn't have that protective covering, and it's immediately destroyed in the stomach. And so all the proton pump inhibitors are safe during breastfeeding, no matter what the pediatricians tell the mother. Large volume of distribution. What does that mean? It means that the higher the volume of distribution, the less drug is in the blood. So typically, antidepressants, where are they supposed to be? In the blood? No, that doesn't do anything. They're in the brain. So very little of the drug is generally in the blood. And if it's not in the blood, it can't get into the milk. So perfect examples of ones I get asked about all the time. I don't know how many women in the world are using Botox, but the Botox stays where it's injected. Otherwise, it's of no use. And if it stays where it's injected, then it doesn't get into the milk. It can't bother the baby. I mean, and yet every time somebody gets Botox, I get an email, can I take it? Which makes you wonder about the people who give the Botox to the mother. Don't they know what they're doing? Don't they know their drug? Obviously not. All right. Water-soluble, acidic, ionized, less, but difficult information to find. Large molecular weight. We know that any drug with a molecular weight of greater than about 600 to 800 Daltons does not get into the milk. So a perfect example of drugs that are being used more and more in clinical medicine are the what are they called now? The monoclonal antibodies, right? Everybody's getting monoclonal antibodies, and the drug companies love it because they charge a fortune. Anyway, that being that's beside the point. The point is that they have molecular weights of 140,000, 150,000. There's no way they're going to get into the milk. But they're also proteins, right? So even though they are proteins, even though they don't get into the milk, well, let's say through some miracle they do get into the milk, they are proteins, and they will be destroyed in the baby's stomach just like any protein. And if, by chance, they get past the stomach, what would happen to a whole protein that got into the small intestine? It wouldn't be absorbed. It would end up in the baby's diaper. And yet, consistently, mothers are told, you can't breastfeed with Enbrel, with this or that. Okay. And a short exposure also makes a difference. So we treat what? We treat ectopic pregnancy, for example, in some cases with methotrexate, 1 dose. That's okay. It's only 1 dose. Methotrexate, on the other hand, treating rheumatoid arthritis long-term is a problem because it gets into the baby's gonads, and we don't know what that's going to cause, even though small amounts only get into the milk. And the final underlying issue here with drugs is that very, very little gets into the milk, no matter what drug it is. So, let us give an example. A breastfeeding mother needs to use something for arthritis, a very common problem in young women. A common problem. I wouldn't say very common. It is decided that a non-steroidal anti-inflammatory drug is best to start with. Okay, for the sake of argument, let us consider 4 possibilities. Ibuprofen, ketorolac, naproxen, diclofenac. And I'm telling you that all these drugs have been told to various mothers they can't breastfeed while taking this. So, what about the protein binding? Ketorolac, 99%. Ibuprofen, more than 99%. Naproxen, 99.7%. Diclofenac, 99.7%. In other words, only less than 1% of the drug in the mother's blood. And the mother's blood has very low concentrations of all these medications. Only less than 1% will get into the milk. Half-lives, various, all over the place. So, from this point of view, maybe diclofenac is the best because it's only got a very short half-life. On the other hand, ibuprofen, at least where I live, does not require a prescription. So if you can buy it for less, then buy it. It's fine. My physician prescribed trazodone, and I called Mother Risk to verify its safety, which they said was less than 3% in the milk. An estimated 0.6 is actually absorbed by the baby by estimation. So, fine. They said it was fine. But the mother would be completely, ununderstanding what this means. Basically, it means it's okay. So, for example, a 6-kilo baby, 60-kilo mother, baby weighs 10% of the mother, baby gets 3% in her milk, and the mother will start worrying if she even thought about how to do that. Anyway, almost all drugs are safe for the baby, because the amount that gets into the milk depends on the maternal blood concentration, which is very low, often measured in micrograms or even nanograms per mil. And the reason I'm spending most of the time on medications, drugs, is because this is the most common reason that mothers are being told they must stop breastfeeding. There are other reasons. So, for example, if a mother has rheumatoid arthritis, some doctors would think, okay, many doctors, unfortunately, believe that breastfeeding is a burden for the mother. That, she's only doing it because she has to, for the sake of the baby. And so mothers will be told, oh, you have rheumatoid arthritis. Many people are tired when they have rheumatoid arthritis. Why don't you just stop breastfeeding? But even if they don't do that, they also, it's the most common reason for mothers. I get at least 5 or 6 emails every single day, and that's a minimum, about drugs and breastfeeding. With very few exceptions, breastfeeding can and should continue. The real question is, which is safer for the baby? Breastfeeding with milk containing minuscule amounts of medication, and it's almost always minuscule, or formula. And we talked yesterday about how the risks of formula feeding and so forth and so on, but we never take that into consideration when we talk about drugs and breastfeeding. Breastfeeding decreases the risks of many things for the baby. Or we put it a better way, formula has risks. And the question is, which is safer for the baby? Breastfeeding with small amounts of drug or formula? And the answer is, well, the drug we call formula is not usually safer for the baby. Okay. So, not contraindicated. For years already, we've known that metronidazole or flagyl is not contraindicated in breastfeeding. It doesn't matter. Mothers are told you can't breastfeed. We give metronidazole intravenously to 500-gram babies, and that's okay. But the baby gets a tiny amount in the milk, not good. Prednisone, common problem. No reason to stop for prednisone. Alcohol. The amount of alcohol that gets into the milk is tiny. What's the legal limit in Greece before they give you a big ticket and take away your car if you're driving with, 0.05% alcohol in your blood? 0.08? 2.1%? That's it? Oh, yes, 0%. Okay. Sorry? Okay, all right, so 0.5. So alcohol is like water, basically. It goes back and forth between breast milk and blood like as if it were water. Well, if you have 0.05% alcohol in your blood, you have 0.05% alcohol in your milk. 0.05%, you could drink that all day and all night, you'd never feel it, and neither will the baby. And in any case, when the blood alcohol drops, the alcohol in the milk, in the breast, goes back into the blood. Now, the real problem with alcohol, and also drugs like marijuana and cocaine and all that, is that the mother usually is the responsible person for the baby. And if you are not quite with it, if you are impaired, then you cannot react to the baby's needs. And that sometimes are important needs. So, for example, we had a mother a few months ago, or maybe longer than that now, who had something to drink. All of a sudden the baby becomes sick. She's worried. She goes in the car, and she has an accident. Now, nobody got hurt. Nobody got killed. It's not as bad as it could be, but I think we have to consider that sort of thing. Interferon, much too big to get into the milk. Nicotine, better to breastfeed and smoke if you have to, than to formula feed and smoke. These are the monoclonal antibodies. There are now dozens of them. Every disease has something for one of these drugs. Tetracycline. Who thinks tetracycline is contraindicated in breastfeeding? Pharmacists, what do you tell your patients when they take tetracycline don't take it with? No, they don't take tetracycline when you take milk. Okay, so first of all, there's very little tetracycline in the milk. But how does the baby get it? With milk. So it binds to the calcium and ends up in the baby's diaper. Vaccines. I can't believe that I get asked about vaccines, but anyhow. Okay, so how strange is this approach to drugs and breastfeeding? A mother of a 3-month-old baby calls our clinic. Now, this I talked about yesterday, actually. There's something I don't understand, she says. I went to the doctor a few days ago for a cold. That's a big problem to begin with, of course. The doctor told me to take amoxicillin, also a problem because colds do not get better because of amoxicillin. But I would have to interrupt breastfeeding as the baby would get some of the drug. Today I went to the doctor because the baby started a cold. The doctor put the baby on amoxicillin. There's something I don't understand. And this also is not made up. My friend has been nursing her 6-month-old exclusively since birth. She was just put on Tamiflu yesterday after testing positive for the flu, at which time she stopped nursing and fed baby from a frozen supply. The baby has now tested positive for flu and is on Tamiflu. Should the mother go back to nursing her baby? Could the baby receive too much Tamiflu from the breast milk? You see, this is what lay people think, is that the amount of drug we give to somebody is so precise that if you get a tiny bit more, that's too much. Pharmacist, is this true? Okay. In your opinion, is the fresh milk or frozen, drug-free milk more beneficial for the baby fighting the flu? Okay, so now we talk about radioactive iodine. This is an issue. Well, we can avoid it if possible, and it's not necessary to do a thyroid scan. I won't go into this in too much detail because it... okay, it just takes some time. Okay, well, I'll keep talking while the interpreters interpret. Okay, so this is the most common reason why a woman who's breastfeeding would get radioactive iodine, and that is to differentiate postpartum thyroiditis, which is pretty common, from Graves' disease. But as you heard a few minutes ago, Graves' disease is less common in the first few months than postpartum thyroiditis. The thing is, you don't have to do the thyroid scan. What I've always recommended is, well, it's possible to use I-123 instead of I-131 because I-123 requires only 12 to 24 hours interruption of breastfeeding depending on the dose, whereas I-131 requires a much longer time. But the mother should express her milk in advance so the baby can get breast milk, not formula. Pump, do not dump, because radiation do not throw it away because radiation decays, and the milk will eventually be radiation-free. In the case of I-131, it will be radiation-free in about 40 or 50 days. But there's a better way. Breastfeeding... what did I do there? Hold on. Okay, so what we have been teaching mothers is just wait and see. Treat the mother asymptomatically for her irritability, her tremulousness, her cardiac arrhythmias with propranolol, and wait. And wait. Within about 6 or 8 weeks, somebody with postpartum thyroiditis will have a decrease in their T4 and T3, and it'll be getting better all by itself, which Graves' disease does not. I think that radioactive iodine should be avoided if at all possible, even if it's Graves' disease that's not controlled, because I have had both thyroidectomy and radioactive iodine. And let me tell you that getting radioactive iodine sounds better to begin with, but it's not better. First of all, before you get your radioactive iodine, you have to go on a special iodine-free diet. Let me tell you how miserable that is. It's awful, right? Second of all, once you get your radioactive iodine, you are isolated from everybody, including, if you're a nursing mother, from your baby. And in some places, it's usually, at least we're in Toronto, you're isolated for a week from your baby. In other places, it's even as long as a month. And so that's the end of breastfeeding. Everything that you do in the hospital with your radioactive iodine is horrible. You cannot touch anybody. You cannot. There's a window that you can't even be in front of somebody. And everything, you have to collect all your bowel movements and your urine and everything. You don't want to do radioactive iodine. Let me tell you that thyroidectomy was a pleasure compared to it.
Sorry, but we are going to miss from being interpreted in the PowerPoint 20 of your slides. Sorry.
They're
and
gone?
then we will catch up again in marijuana because we are in Crete. Yeah.
Okay. Well,
from cannabis, we will begin again having the translation. Okay.
All right.
Thank you.
So just carry on? Yes. Okay. So treatment with radioactive iodine requires isolation, usually in hospital for at least 3 or 4 days, and from newborns for at least 7 days, requiring collecting all bodily secretions, stool, your clothing, which is hospital clothing, has to be collected, special bags, and Radiation is radiation, and I think that we should take into consideration that most nursing mothers are young. So they're getting radiation at the age of 20, 30, 35, 40. They have 40 more years to live, maybe even longer. But radioactive iodine, what does it do? It does all sorts of things. You've been exposed to large doses of radioactive iodine. Okay, so the only time I-131 must be used is for treatment of possible metastases of carcinoma of the thyroid, but does it really need to be done? The decision to use radioactive iodine should not be routine, and that's the problem in many places, is that it's done routinely. In many cases, it doesn't have to be done. You weigh the pathology of the cancer against all other things, including how advanced it is, if there are metastases and so forth, or if there's transfer to the lymph nodes. But if it's plain ordinary papillary carcinoma, there's no metastasis to the local lymph nodes, you can probably just watch and you can see how things are going. And so no thyroid tissue, the radioactive iodine will be quickly eliminated from her body. She can express her milk to get rid of the radioactive iodine, and one can check for radioactivity from time to time and restart breastfeeding when it's gone. There may be another issue. It's possible that radioactive iodine could damage the alveolar cells of the breast, those milk-producing cells, and compromise future production. Maybe. But, ultimately we have to weigh the risk against that possibility. Every rapidly growing cell is a target for radioactive iodine. There are those that suggest stopping breastfeeding at least a week before the mother gets radioactive iodine, except that very few mothers are dried up within a week. I mean, seriously. Theoretical concern, but it's not proved. So, as I mentioned, postpartum thyroiditis versus Graves' disease. If the mother presents with the symptoms of hyperthyroidism and hyperthyroidism is proved, treat symptomatically and follow her function. Propranolol can be used and is safe during breastfeeding. Usually within 6 weeks or so, the thyroid function will be normalizing with postpartum thyroiditis. Postpartum thyroiditis is the most likely diagnosis for a mother 4 or 5 months postpartum. Other scans using radioactive tracers avoid if possible. Doing an MRI or CT scan or some other test rather than a radioactive scan is often feasible and even preferable. MRIs and CT scans do not use radioactivity, except in rare situations. So, if radioactive tracers are unavoidable, the mother should express her milk in advance so the baby can get some breast milk instead of formula. Milk expressed after the test until the mother restarts breastfeeding can be saved and can be used after waiting until radioactivity has decayed away. Technetium is probably the most common radioactive isotope that we use. It has a half-life of less than 6 hours. Therefore, 98% of it will be out of the mother's body within 5 half-lives. So why do so many radiologists tell the mother to stop breastfeeding 48 or even more hours? Don't know. Actually, 75% will be out of the mother's body in 12 hours. And in my opinion, 6 to 12 hours is long enough because we do take this type of scan on small babies sometimes. HIDA scan is for the gallbladder. It's done with technetium to look at the gallbladder. Technetium is radioactive, so the mother has to stop breastfeeding. Right? Wrong. Since the isotope is trapped in the gallbladder and then excreted into the mother's intestinal tract, it doesn't get into the milk. The isotope is attached to a carrier which takes it to the gallbladder. MRI. Very, very commonly, mothers are told they must stop breastfeeding for at least 48 to 72 hours if they get an MRI. Gadopentate is the contrast medium, and it's not radioactive. The amount that is excreted into the milk has been measured at 0.04% of the maternal dose. The amount absorbed from the gastrointestinal tract is 0.8% of the ingested dose. So you can see how little will get into the baby. The half-life is 1.6 hours. We use this for babies, by the way, even premature babies, and so I see no problem. The material used for CT scan is iodine-based and is a complex substance which will not get into the milk. That's because it's attached to a big carrier. The amount of iodine which gets into the milk after IVP, intravenous pyelogram, lymphangiogram, etc., is very small indeed and will hardly increase the amount of iodine in the milk over what is already there. These are 2 links to the American College of Radiology, and they're basically saying you don't have to stop breastfeeding. This is for the iodinated compounds. They say you don't have to stop breastfeeding. Well, what about drugs of recreation and abuse? The principles are the same. Alcohol, I've already mentioned, and so I will carry on. What is the concern? Again, if the mother is too impaired to take care of her baby, this is a serious issue, but this does not make the milk itself dangerous. One study showed decreased motor activity in babies whose mothers were daily heavy users of alcohol while breastfeeding, but took the mother's word for it that they did not drink during pregnancy. Now, how did they figure that one out? Decreased milk supply with alcohol, that's what they say, but we don't know that. Marijuana, the breast does not know that the drug is illegal. And in fact, come July 1st, it will be legal in Canada. Marijuana does not act differently from other drugs. In other words, very little gets into the milk. It is 99.9% protein bound, and less than 20% is absorbed from the GI tract. So the babies will be okay. If the mother is a constant heavy user, this is perhaps a different situation. Even small amounts will eventually accumulate in the baby's body stores. What is the significance of that? We don't know. Nobody knows. But if the mother smokes an occasional joint, does formula really become safer than breastfeeding? No. The issue is not the THC in the milk, but rather, as with alcohol, if the mother is a constant heavy user, can she take care of her baby? Methadone, very little gets into the milk, just as with any other drug. Even large doses, say 120 milligrams a day or more, does not get into the baby in significant amounts. There is no maximum therapeutic dose over which breastfeeding is contraindicated. And certainly the baby gets less exposure than during pregnancy. Therefore, we should encourage the mother to breastfeed. These are difficult drugs, that's for sure. Heroin, cocaine, methamphetamine. These drugs represent a more difficult problem for sure. Regular users of hard drugs rarely breastfeed, but their babies are at high risk of illness, morbidity, and mortality. Should the baby be apprehended? Not my decision. If not, should we encourage breastfeeding? And I would say the answer is yes. If we tell a pregnant woman, you can only breastfeed if you stop using, probably she won't stop. The baby will be apprehended and the mother will remain addicted. We are telling her that her milk is dangerous, even toxic. But having a baby and breastfeeding can be life-changing experiences. If we say to her, here's your chance to make a change in your life, breastfeed but stop using, maybe, just maybe, she'll go into rehabilitation. And in fact, we see it. We see this in Australia, where they took that approach. Mothers went into rehab with their babies, of course, and many stopped using these drugs. The experience, that's what I just said, hold on. The experience of encouraging women to breastfeed in rehabilitation clinics in Australia has been very positive. Now, this is a few years ago, so I don't know if they're still doing it. What about the baby in withdrawal? If the baby is showing signs of narcotic withdrawal, should we refuse to give the baby the mother's milk? We will give the baby opium, paregoric, morphine, but we worry about the tiny amount of narcotic in the milk. Exactly. There is not enough narcotic in the milk to prevent withdrawal. One study suggests you can diminish the symptoms by breastfeeding or breast milk, but could this be due to the mother holding the baby, right? You have to at least hold the baby. SSRI antidepressants, only tiny amounts get into the milk, but there have been withdrawal symptoms in the SSRI antidepressants as well. This study, breastfed neonates exposed to opioid maintenance treatment medication prenatally and methadone-exposed newborns in particular have lower incidence of neonatal abstinence syndrome and require shorter pharmacotherapy for neonatal abstinence syndrome than infants who are not breastfed. The results add to the evidence regarding the benefits of breastfeeding for neonates prenatally exposed to opioid maintenance therapy. Okay, what about infant illness? Breastfeeding is best for premature babies, even the smallest ones. We have 3 articles on our website for premature babies and show really how we've completely missed the boat in most of the world in the treatment of premature babies and encouragement of breastfeeding. Gastroenteritis, we talked about this yesterday. The best treatment for gastroenteritis is breastfeeding. Respiratory illness. We used to think, you don't give milk to babies with, say, croup, because it makes the croup worse. That's nonsense. It's not true, but people still think along those lines. Cleft palate, other anatomic abnormalities of the face. They can at least get breast milk. But some babies, as you saw yesterday, do get latched on with cleft palates and can breastfeed. And if we don't try, for sure it's not going to work. Some metabolic diseases, so we don't know for sure. But some babies with galactosemia don't have a complete absence of the enzyme that metabolizes galactose. And if they have a reasonable amount, they could breastfeed. Some babies have 20 to 25% of that enzyme, and they should be able to breastfeed. Also, tyrosinemia. What's the treatment for tyrosinemia? Low protein formula. Except breast milk has very little protein in it. And most of the protein in breast milk is not absorbed. What are the major proteins in breast milk? Lactoferrin, which is about 70% of the protein, and antibodies. Altogether, they make up at least 70% of all the protein in breast milk, and none of it is absorbed. So we're talking low-protein diets. Hyperbilirubinemia. Oh, I'll have to come back and tell you how to deal with hyperbilirubinemia. Failure to thrive. Well, you saw the video of that baby who was 5 months, who obviously was failing to thrive, and we treated it. The baby was treated differently than most doctors would treat. A hospitalized child needs breast milk and breastfeeding more, not less, than the average baby living on the outside. What about maternal illness? Fever, cough, diarrhea, rash. By the time the mother has got this viral infection, she's already passed the infection over to the baby. It's too late to separate them, even if that were a good idea. But breastfeeding protects. Mastitis and breast abscess. Continue breastfeeding, for goodness sakes. These are articles on our website. Go to them. Breast augmentation or breast reduction. Many mothers who have had surgery of the breast with the incision around the areola do not produce all the milk the baby needs. But some do. And furthermore, breastfeeding is more than the breast milk. So the mothers can supplement with a lactation aid at the breast and continue breastfeeding. Postpartum thyroiditis, already mentioned. Radioactive isotopes, already mentioned. And so forth. What about chickenpox? Okay, this was always a big issue. But, you know, most people now are immune to chickenpox. Okay, a mother gets exposed to chickenpox. Should we tell her not to breastfeed because she's going to deliver in 2 or 3 days? Well, the baby has already been exposed. There's no question about that. There's a viremia, that is, the virus is in the mother's blood and will get to the baby even before she knows she's been exposed, or perhaps before she knows she's sick. West Nile virus. I don't know, do you have it here? Okay, well, West Nile virus is not a contraindication. There's never been a case of a baby getting West Nile virus through the milk. There's one baby where they did document West Nile virus in the milk. The baby became immune to West Nile virus but didn't get sick. Lyme disease, again. And the treatment of choice, doxycycline, is it contraindicated during breastfeeding? No, it's not. I'm not going to explain it. You just look it up. What about hepatitis A, B, C, and down to Z? Because one day we will have hepatitis Z. No. Again, by the time the mother knows she's sick, she's already passed on the infection. Rubella, same thing. Cytomegalovirus. Well, if the baby's born with this syndrome of cytomegalovirus, he's already got it. Immunizations, I already mentioned. HIV, if the mother is treated through the pregnancy and the baby is treated as soon as he's born, there is no increased risk with HIV. There are some studies here. I'm just going, there are a few studies that show basically that the risk of HIV, now these were done in Africa, and where the risk of death from not breastfeeding is not insignificant at all. So they're saying it's okay, it's better. But that was before. These articles were published before treatment for HIV was generalized to pregnant women and the new baby. Exclusive breastfeeding does not seem to increase the risk of transmission of HIV more than exclusive formula feeding. In fact, there may even be a protective effect. But again, it's the partial breastfeeding with any supplement that significantly increases the risk of transmission of HIV. And now that we are treating, this is the latest WHO statement on HIV and breastfeeding, which is basically saying it's okay. What about a new pregnancy? I've already mentioned that it's not a contraindication. I gave a few references for that. I did it again. All right. Okay. Hospitalization of the mother. If a mother needs to go into hospital, the baby should come with her. A mother and a baby, a breastfeeding baby, are a unit. They are one. They are a dyad, and they should stay together so that breastfeeding can continue. There's no increased risk of infection to the baby if the baby is hospitalized with the mother. Hospitalization of mother and baby together should be the norm. We once said it was not good to have parents stay with the hospitalized children, and we changed. It wasn't that long ago. Some of you were even born at that time. It wasn't that long ago when I was a resident in pediatrics that they only allowed the parents to stay a few hours a day with their baby. There was a time, not long before I was a resident in pediatrics, where the babies were allowed visits only on Sundays. That's terrible, but that was considered normal. I once was at a hospital, not a hospital, but I was giving a talk in Southampton in England, and they had a history of the National Health Service. And one of the plaques was 1954, parents now allowed to visit their hospitalized children. It sounds like they never were allowed even on Sunday. And here's a woman in the adult intensive care unit. She had a severe bleed after birth of her baby. She lost her uterus. She's still intubated, as you can see. She's got a nasogastric tube. And there's one of the lactation consultants at the hospital helping her with breastfeeding. And why not? That's just a side view of the same thing. And there is Madame Renoir breastfeeding her big fat toddler baby. Not the one who made films, but his brother. Okay. And I showed you this. Okay. And the contact information, it's all there. Okay. I don't know if we have time for questions. Oh, yeah, we had lots of time. All right. Questions? Outraged remarks? Oh, I need my headphones if you're going to speak in Greek. Somebody got earphones? No, I think we have some. I have some in the back. All right. Is it in Greek or in a... I will tell you. Okay, so now...
Κάποια ερώτηση?
Is there a question?
It's irrelevant with your with this talk. It's a question I wanted to ask yesterday, and now I remembered it. Yesterday you said about late preterm babies and early...
What sort of babies, sorry?
Late preterm babies and early term babies, and you consider them as capable of breastfeeding exclusively.
Yes.
And I would like to ask, yes, they may be, about early terms, they may be able to latch on the breast, they may be able to begin a good meal on the breast, but because of their low stamina and their hypotonia, will not conclude the breastfeeding and will get off the breast hungry, but you will never know because they're sleeping. So how do you make it? Because we don't.
Well, do it.
How? They sleep.
Because you're making a false assumption. And the false assumption is that breastfeeding takes a lot of work. It doesn't. Babies respond to milk flow. If the flow of milk is rapid, the baby will stay awake and will drink. And this is...
Yes, but they have a sleep-wake cycle which is not normal. They don't wake up to feed. Okay?
They do if they feed well. Yes, take my word for it. Give it a try. Look, the reason that we have this idea is because we have this idea to begin with. And the fact of the matter is, if we teach babies and mothers to get on the breast as well as possible, the milk flows from the mother. If the milk flows from the mother, the baby remains awake and continues to drink. The whole notion that babies require stamina in order to breastfeed is a false notion. That false notion comes from the idea that babies transfer milk. But babies do not transfer milk. Babies stimulate the breast so that the mother transfers the milk. It takes no energy to breastfeed, and certainly not more energy than to bottle feed. So teach those mothers to latch on well, their babies. Teach those mothers how to know the baby's getting milk. Teach the mothers how to use breast compression to keep up the flow of milk. And when the flow of milk is starting to slow down, even with compression, then take the baby off and offer the other side. And I will guarantee you it'll work. This is my guarantee.
I'll check it.
Just like Nestle, I give you a guarantee.
Okay. I have another question. Can I tell it now? Any insights on very, very big breasts that are difficult to manage? What can we do?
Same thing as always. We have lots of mothers with very big breasts. The babies latch on. If they go to the breast and they get milk, they stay there. I know. Give it a try. Come visit us in Toronto. You'll see what we do. We have very good Greek food in Toronto.
Yeah. Okay. Professor Newman, is one question I wanted to make yesterday, but I didn't have the chance. I'm from Cyprus, and there we have a great enemy, which is the dentist.
Oh, I thought you were going to say the Turks. Okay.
Well, also.
The dentist, yes.
Yes, but the dentist, they say, don't breastfeed after the age of 12 and 12 months.
What do dentists know about breastfeeding?
I know, but one of the pediatric dentists, she wanted to come to the hospital and lecture the midwives to advise the parents not to let the children, the babies, breastfeed after the age of 12. It's amazing, but they feel 12 months, okay, it's supposed to be. But I just wanted you to tell me if the baby sleep on the breast, if there is milk in the baby's mouth, and if that milk can cause caries.
No. The answer is no, because the milk doesn't stay in the baby's mouth. Because the milk, when the baby is latched on the way he's supposed to be, that nipple is at the far end of the far back of the mouth. So if the milk flows, the baby swallows it. It doesn't pool in his mouth the way a baby who is sucking on a bottle in his sleep, it pools in his mouth. So dentists don't know anything about teeth, at least not in breastfed babies. And since breastfed babies are the norm, they don't know anything about teeth at all.
Thank you very much.
Σας ευχαριστούμε και πάλι.
Oh, wait, stop.
Thank you very much. Thank you very much for your kind speech. Now, I would like to have a comment, if possible, about the quantity of milk in K vitamin and whether all children here in Greece need to make the special vaccination for conacuum.
For vitamin K, you mean?
Yes, vitamin K.
Yes. We do it in Canada. We give it by injection, not by oral methods. It's recommended. It's probably not necessary, but every so often some baby really does have a serious problem with bleeding. And so, it's from my point of view, who tries to do everything naturally, except I don't eat naturally, but that's a different story. Giving one injection to a baby is no big deal. And it does prevent, and I think every pediatrician has seen a baby whose, the parents refuse to get the vitamin K, and maybe it's only one in 100,000, but we've all seen babies who bled into their heads when they didn't get vitamin K. So I don't know. I think it's a small thing to do. I think that they should get vitamin K, even though the necessity for it is hardly well proven.
Thank you again for your excellent talk. I would like to ask you if you think that breastfed babies need iron supplementation.
Need what?
Iron supplementation.
No, I don't think so. I think that unless the baby was very premature or the mother was very anemic during the pregnancy, then most babies are born with adequate stores for at least 6 months. And there are theoretical reasons why this is good. And one of those theoretical reasons is that iron encourages the bacteria in the gut to grow, that is, bacteria that are pathogenic bacteria, to grow in the baby's gut once they start eating food with a lot of iron. And the theoretical reason, and maybe this doesn't happen in our situation where babies generally are protected, but I think that iron is, has been made into a huge issue, that all these babies need iron. But it's based on the fact that formula-fed babies had problems with iron, or babies that were on cow milk only had difficulties with iron. But that's not the same thing as the breastfed baby. And I think if the baby is exclusively breastfed, as we recommend, and starts eating food normally, most of these babies will be just fine. And I don't think that it's absolutely necessary that babies get supplemental iron, except in the two situations where I mentioned it.
Thank you.
Who?
Levi.
The question's about late. No. I heard. The question is about late cord clamping. And of course, the real answer is it's not late cord, it's normal cord clamping. In fact, I saw a very interesting demonstration where the cord was not clamped at all, where there was a demonstration from an obstetrician where he said he never clamps the cord. And he showed these things in videos, and there was the end of the cord, no clamp, no bleeding.
Yes, but they say maybe polycythemia.
No, polycythemia is a disease. Having more red blood cells, according to the studies, is actually very good for the baby. And there are some studies that show that it decreases... Now you've caught me. I forgot what the study says, but it said it was good.
Hello, it's me.
Where?
Here.
Okay.
Cyprus here. This question is from yesterday. I have a lot of ladies. We oversupply.
Oversupply?
Yes.
Never heard of it.
You never heard?
I don't believe it exists.
Exists and bothers.
No, listen here. How do we diagnose oversupply? We diagnose oversupply because the baby chokes at the breast, coughs at the breast. Well, what is oversupply then?
Spreading like this, like crazy, and doesn't stop producing gas.
Fix the baby's latch and you won't have oversupply. It'll happen. It gets better. It gets better. Well, what are you going to do?
In the first month, Dr. Jack.
Yes, ma'am.
It's oversupply. First, maybe the most of the moms, I go and visit all over Cyprus. You know that. It's engorgement. When we help them and release the engorgement, they start to have oversupply. The baby is 2 weeks, for example, needs approximately 90 ml of milk. But the milk comes like a fountain, Sintrivani, fountain. So the baby gets, of course, we don't separate fore milk and hind milk, but there is the fore milk with a lot of lactose and the hind milk with sugar. So the baby gets the first, even the breast is big anyway, even if it's not big, the baby gets the fore milk, sleep because it's fast flow, sleep on the breast, awake again in 1 hour. And we have all these symptoms, which I call colic babies. What is these symptoms? If you agree,
no.
You are the expert. Frothy with spit up stools, gas, air. Every hour they want to breastfeed. They put a lot of weight. I find this. Don't you find this everywhere?
All right.
Hot, okay. If I go to, I just finish. If I go to the mother, of course I do this very nice, compressed feeding. But if the mother calls me from the other side of Limassol, how can I solve the problem? Please.
Well, you can use videos, which I'm going to send you as a CD.
If the mother doesn't understand videos, what shall I say to her?
What can I say? I think that you have to go to the other side of Cyprus to help her.
Oh my God, I can't be anywhere.
No.
What do you
the
advise?
most common reason that mothers are told they have oversupply is because the baby goes, this may not be the only reason, but this is the most common reason, is that the baby goes to the breast and he starts to cough and he chokes and he pulls off the breast and he cries.
Yes.
But that's because the baby's latch is not as good as it could be. And because if the baby's latch were better, the baby would be able to control that flow. And there's nothing wrong with aspirating a little bit of breast milk on the way down.
Don't you agree? Last thing, if she's away and she call me and all this, I agree that the baby gets only. I tell her to do express and give the baby for 24 hours. You don't agree with this?
Don't take babies off breast.
After the baby calms down.
Okay, so when I go to Cyprus, I'll show you what I do.
Okay, next meeting I hope will be in Cyprus. Thank you.
Ευχαριστούμε τον Dr. Newman.